The key thing, I think, in casuistry is to not try to apply one given set of methods to a case. There are many different methods to solve cases. Siegler and Winslade and Johnson, for example, use several principles: medical indications, patient preferences, then looking at functional considerations, then looking at external factors, and they apply this grid to each case. David Tomasma has another grid that he uses. Others, like Beecham and Childress, use the 4 principles of ethics: autonomy, beneficence, non-maleficence, and justice, and apply those 4 principles to cases. Is this an autonomy case, for example? A 50-year-old man with severe heart disease, and he's refusing surgery, and the doctor suggests surgery. His autonomy says that he can refuse surgery, that the refusal of surgery is not suicide. The patient's preference, in that sense, will trump the doctor's medical recommendation, medical indications. So that's the one way to look at principles applying to cases. There's nothing wrong with that. We need to use principles. And in the Christian sphere, we use other principles too. We use the principle of God's sovereignty. We use the principle of our free will. Many of these principles can be used. But casuistry is really different. The case itself speaks to the solution to the case. The solution is within the case itself. I do think it's different than situation ethics. We're not trying to do the most loving thing necessarily, which is situation ethics, to solve a case. We're basically saying, after you see 500 of these kinds of cases, how do you solve them? And part of it's just an experiential skill. In the lecture today, I'd like to go over how to do a consult, starting with beginning the consultation, then preparing to see the patient, seeing the patient, conducting family meetings, preparing an ethical analysis, and then writing the report and the follow-up. The first thing when we're called to do a consult, the most kind of primitive and primal aspect is, who am I doing the consult for? Who do I work for as a consultant, as a casuist, a case solver? If I'm on an ethics committee, I report to the committee. But who am I really working for when the consult's called? The first and obvious answer is, I'm working for the patient. And I think we always need to work for the patient. But we also work for the requesting physician, or a nurse, or other requester. We sometimes are agents of the hospital, but we don't want to just be an agent of the hospital. We could be even conceived of as an agent of society, working to some degree for the common good. But we don't want to just do that. And I usually say that the key thing is to at least make sure that the requesting physician or nurse is involved in the case, that they come to the consult, when there's an ethics committee meeting, that they're present there, and we understand that we're at least beginning the consultation, that we're responding to their request for help or the patient's request for help. Very important part, and there's a lot of nuances in the request for consultation. One thing we must always know about is, besides who is the requester, is what are the issues that are being asked. For example, one case I was asked, is it okay to stop tube feeding in this elderly patient with a stroke? And I thought that was the question, but when I got to hear more about the case, I realized that the physician was really asking, am I spending too much money on this very sick patient with the tube feeding? And not about the tube feeding itself, but the issue of keeping the patient alive. So the question was not, is tube feeding ethical or unethical, but is this patient's life worth saving? Which I think is a much more complicated question than, is it all right to withdraw tube feeding here? We determine the urgency. We actually carry beepers in our consultation service, but most cases are not urgent. And sometimes we use time to help us solve cases. We say, let's come back in a day or two and see how the patient's doing. But we have to look at urgency, and one would not want to say, the ethics committee meets every third Wednesday of the month. We can't help you to that till Wednesday, and the the doctor or nurse or patient really needs urgent help. Again, very, very infrequently, very rarely do we really need to do a consult in that minute. But if you do, it's nice to at least be available and to try to help them. So we look at the issues, we determine the urgency, we try to clarify the question, and then if I have any dogmatic statement about this, is that you must see the patient. Many ethics committees and ethics consultants struggle with this issue, but for me it's actually simple. You must see the patient. Charles Culver tells a story of a very sick patient. The intern comes in to present the case, says here's the patient's case. Ethics committee says, let's let the patient, let them die. A month or two later, another case, the ethics committee is sitting to hear the case. Intern comes in, presents the case. The decision is, well, given how things are going, let's let the patient, let's keep going. Same patient. The patient condition had not changed at all in the ensuing month or two. But what had happened was a different intern had presented the case. The ethics committee didn't even know it was hearing the same case twice. And that is the reason that, one of the reasons that one must see the patient when one is doing case consultation, case solving. You must gather your own data. You must verify that the case is as it's presented to you. You must find out if there's any more information. And it just is essential to see the patient. Imagine making life and death decisions or helping to make them in some conference room away from the patient. I can't imagine anything more dogmatic or paternalistic than saying, let them live or let them die without even seeing the person. Seeing the patient, of course, also helps in terms of being able to see the patient's chart. And we ask that consultants not be naive about what's in the chart, that they review the history of the patient, they review what's written there. It's a multidisciplinary record of the patient's actual history. So key to look at the chart, see the patient. Then, as we see the patient, we observe what the patient's situation is, we gather our own data, and actually we establish a relationship with the patient. And we use a fairly casuist model in terms of medical model. We try to get to know the patient as a consultant and not, again, sit in a room. We introduce ourselves to the patient. We allow the patient to speak without interruption using some of these techniques. Let them speak for several minutes if they're able. Ask open-ended questions. We don't usually say, what brings you here? Because the patient says, I can't, the bus. My car. But we say, I often use as an interviewing technique, tell me about your situation. That allows the patient to describe their actual situation that they perceive, their life story. Tell me about your situation. I get the information. If the person's comatose, I talk to the nurse, I talk to the family. I still look at the patient because even seeing the patient in a comatose condition, I can learn something about this patient. How many tubes are there? How tense is the abdomen? What books are by the bedside? Is there a Bible by the bedside? I mean, many things you can learn about a patient, even when they're comatose, when you see the patient. So we've began the consultation by identifying the issues, clarifying them. We prepared to see the patient by looking at the medical record, perhaps speaking with other people as we're going to see the patient. We've seen the patient, even if they're not able to speak. They deserve the right to be seen when one is helping to make life and death decisions in terms of casuistry or case solving. Sometimes we need then to have a family meeting. I usually let the requesting physician or nurse call the meeting and be there. If they want me as a consultant to run it, I will do that. But I usually just try to be a facilitator there and help encourage a good family meeting. Sometimes we help prevent, I think, malpractice cases even. When there's a lot of disagreement or argument, we act as a sounding board, our ethics committee. And the ethics consultant is part of the committee. we often have a small ethics consultation team, can really facilitate that process. So we've had the consult, seen the patient, had the family meetings, and then it's time to prepare an ethical analysis. And the good casuist will prepare an analysis that makes sense to the case. So if the case is about a 13-year-old girl who has Huntington's chorea and is dying of this disease at a very young age, unusually young age, then as a casuist, I need to go and find out the information about Huntington's chorea in a 13-year-old. I need to bring that information to the table, and when I write the report, I need to provide this reference. I need to attach some of these references. I like to write less than 4 recommendations if I'm making dogmatic recommendations. I need to address the questions asked. And as Dr. John LaPuma and I mentioned in our consultation book, the key thing on writing a report is that there's some kind of legal record of the consult. If nothing is left on the chart, we don't know that the consult was even done, and no other consultant would do a consult without leaving some kind of record. We address the question asked, we provide a number of recommendations and references. And what if it's a very controversial case? One of the best consultants in the country, Dr. John Fletcher, says you get to make 1 enemy a year in ethics consultation. I mean, one does not want to go in the process of causing trouble, setting oneself up as a moral policewoman to come in and say police things. But once in a while, one's asked the question that the recommendation will be onerous to the physician or nurse. I remember one case where the physician was not seeing the patient, had not seen the patient for about a week, sending in other people, and the ethical issue was that the doctor was not seeing the patient. So there's really a problem here. When we recommend that the doctor has to see the patient, if we write that on the chart, it's really a very sharp recommendation. So what we try to do is say, go to the doctor privately and say, you know, you've got to see this patient. What is the problem here? And not try to leave a note that says the doctor is negligent in not seeing the patient. Such a note would, of course, not only make an enemy, but it would be legally inadvisable to write such a thing. So in ethics consultation, we try to be prudent about this kind of thing. And a good casuist, you're trying to solve the case, not create a lawsuit. What you want to do to solve the case is go to talk to the doctor and say, you know, what's going on? I'm going to leave a note, but I want my note to reflect what you're going to do here. What's happening? Perhaps you can avoid making an enemy and still change the case. So we talk with the requesting physician, talk with the nurse, write the note, maybe do it the opposite order, but we want to communicate what we've written, and then it comes time to write up a report, a longer report for the chart. One might want to dictate such a report. Sometimes a consultant might want to keep the report. Again, what's in that report? The casuist doesn't want to be limited to saying, I've gone through the 4 ethical principles, the Georgetown mantra, autonomy, beneficence, justice, non-maleficence. Now I'm ready to write the report, and I'm going to put category A, how the case had to do with autonomy, category B, how it had to do with beneficence. The consultant, the casuist, basically wants to, again, address the case. So the 13-year-old girl with Huntington's chorea, the issue here is a very aggressive disease in a young person. The issue of withdrawal of life-sustaining treatment in such a patient, for example, has to do also with the pace of this disease and the terrible thing of having that disease in a young person. And the fact that the consultant knows, looking at the genetics information, that this is very, very fatal in a young person, and that the trouble is really not with withdrawing any particular treatment. The issue is not tube feeding or CPR, DNR, but the issue is going to be getting the patient into a hospice program, and the issue is changing the goals of treatment. There's no failure here to treat this patient. What we want to do is change the whole goal of treatment to a hospice instead of aggressive medical treatment, because we know from reviewing the course of the disease that will be a rapid downhill course at this time until we get genetic treatment, for instance, going. But at this time, it's a rapidly progressive, very fatal disease in a 13-year-old. And once one knows that, the case is solved in the sense of the issue is switching modes of treatment, not one particular treatment. The casuist does not like to get cornered into saying we have to do this or that. It has to be one thing or the other. There's a range of options that are acceptable in real cases, and that's the key issue, is outlining the range of options. The casuist is not saying that everything's right, that nothing is wrong, but the issues often are not so clearly laid out as one might think, and many things might be appropriate to do. For instance, if the issue is to whether a patient should have, patient's gotten 40 units of blood and is still bleeding, and the issue is, when is enough enough? Have I given this patient enough blood? Can I stop now? Do I have to keep transfusing? The answer is, doesn't have to be, yes, you must stop now, or you must keep going, but you might say, let us try. Let's talk about this. How many more units would be reasonable to give before it's time to give up? When is enough enough? The ethics consultant says, let's discuss it. What is common wisdom? What would be the just right thing to do? As Leon Cass says, we're searching for the just right thing to do in a certain situation, and that is not going to come out of a specific formula. Often, process is as important as outcome. As Christians, for example, I remember we had a case where it was a young girl who was severely injured in a car accident, and her parents did not want to allow a trach to be put into her neck. She was on the ventilator, and they thought that she shouldn't have that. In the course of our consult, I had the chaplain with me, and he said to the family, do you have faith? And they said that they were strong Catholics, and he said, well, what do you think God's will is in your daughter's life? And for reasons that still are not clear to me, the family just broke down crying. I think it's partly because they thought, how could God do this? But it's also other things, and they broke down crying, and the case was really solved by that discussion because they came to see that they didn't know what God's will was specifically, but they needed to let some more time pass and to get this tracheostomy put in so she had a chance to live a while longer and see what would develop, see if she would wake up and do better. So the case was initially cast as, family's not going to let us do this. They're not letting us do our procedure. With our discussion and the chaplain along, the case just changed, and they were willing to do it, and we did not have to persuade them and browbeat them. And of course, that's part of being a casuist, a case solver. Let's do a couple cases, as we often like to do in practicing. One of the questions that always comes up is, how do I get to become a casuist or case solver, consultant? And the answer is by practice. If you do 400, I think I've done about 400 consults, and you start to see this is another consult with a family, a sophisticated family in conflict, whose father is in the ICU, who's not clearly dying but is not doing well, who has no written advance directive but a verbal advance directive saying, don't let them torture me in the ICU. That kind of case comes up all the time, so you get to say, this is this kind of a case. You've seen enough of those that you start to say, in these kinds of cases, if you do this, this happens. If you do this, this happens. Again, it doesn't make one, it's just a matter of experience to say we've got these kinds of cases. There can be paradigm cases, those are classic cases, a case that speaks for other cases, but there's also these marginal cases where you really don't know what's going to happen. The fact picture of the case is so unusual that you don't know what will exactly happen. And those cases are the marginal cases. Interestingly, are the ones in which much ethics law is made. I consider Roe v. Wade to be such a case. It was an unusual abortion case. I consider Cruzan to be an unusual tube feeding case because Cruzan was in persistent vegetative state, which is rare, whereas, say, strokes are common, Alzheimer's disease is common. Most people with feeding tubes in the United States don't have persistent vegetative state. They have Alzheimer's. So we needed, for the law, we needed a case of Alzheimer's. We got a case of persistent vegetative state. We needed a case of, in the abortion realm, of a woman who was considering abortion for some other reason than allegedly being gang raped. And so what we had was an unusual case in that setting and the other settings, and that's what often we see in law. What we need in the case of reproductive technologies, we don't need law about surrogate motherhood. We need law about artificial insemination by donor, or AIH or AID. What we need is the common cases. We don't get those in law, but in consultation you do. So, a couple common cases. Let's do some. The first case I'd like to do. Let's do a quick CPR case. CPR DNR cases are common in the. We have a 70-year-old man who has known heart disease and lung disease, and the request is made by the attending physician to make him a DNR, or do not resuscitate patient. The consult is called by the attending physician because the patient refuses to consent to a DNR order. What do you do? Best way to solve this kind of case is to clarify the question. Why does the physician want the patient to be DNR? The physician says he's getting some pressure from the nurses and from the family to not resuscitate this very sick patient. Why does the patient want to be kept as a code, a full code? That remains to be seen. When you see the patient, you'll find that out. You go to see the patient. Patient says, when the doctor told me about CPR, he said, if your heart stops and you start to die, do you want us to bring you back? And of course, he said, my answer was yes. He said, I play the lottery. I believe in small chances. I mean, this is my life. This is important to me. If there's a chance they could bring me back, even 1 in 1,000, doc, I will take it. So the case is lined up, and the solution is more discussions with the family, maybe a family meeting, more discussions with the patient. If that doesn't work, the doctor has the choice of either making the patient a full code and going along with the patient, or using a futility policy in the hospital. Many hospitals have these now, where the doctor can say, in my view, coding this patient would be medically futile, and I'm not going to do it, and then document. Usually you need 2 doctors to agree that a case is futile, quotes, and then to document that, and then to speak to the patient and just basically advise them that you're not going to do the code. We've done this in 20 or 30 cases. It's very interesting that when you go back to the patient and just say, look, we're not going to do this. We don't think it's going to work. We don't want to do it to you because we don't think it's effective. Patients often say, well, if you'd have told me that in the first place, I would have, okay. So when you show a little bit of backbone and say, we're not going to do this, patients often consent. If the patient then still refuses, then you have the conflict, but you have documented from your side that you're still not going to do the code. Patients often then would have the option of switching doctors, going to the ethics committee themselves. Of course, you've talked to them, so that's been done already. But you've at least gone through this process. Let's do another case. Case of a middle-class, 58-year-old Chicago man who's recently retired up in northern Wisconsin. And he comes in with a vague feeling of muscle discomfort and cramps and tightness. He's had several episodes of involuntary crying and laughter. His voice is starting to change to be higher. On exam, he's alert and oriented. He's mildly dysarthric, difficulty speaking, that is. Bilateral muscle wasting and weakness, most prominent in the hands. Muscle tendon reflexes are exaggerated, and you see some fasciculations in the muscles of his hand. So his diagnosis is Lou Gehrig's disease, or ALS. This is a classic presentation for Lou Gehrig's disease. And you tell him the diagnosis, and you tell his wife the diagnosis, and you explain that it's a progressive disorder of the motor neurons in the cerebral cortex, brainstem, and spinal cord, and that it leads to spasticity, and it progresses on and on. And of course he says, "Doc, how long do I have to live?" And you would say, again, as a doctor, you'd say 2 to 5 years from the onset of the disease. You tell them that right now we're working on treatment. This is a genetic disease, and some people's view there's some genetic issues here, and there may be gene therapy in the future, but right now it's a progressive disease. Suppose his disease progresses rapidly. In a year he's bedridden. He starts on a new experimental drug for ALS. Despite the medication, he gets worse, and 2 things happen in ALS. They become unable to breathe because of respiratory problems, and they need tube feeding. So they need a ventilator and tube feeding through the course of their disease if they choose to have that. So the ethics consult comes from the attending physician who says, you know, I've diagnosed ALS, I've been treating him supportively for a year, he's getting worse, and the patient's asking me to not go on the ventilator. What should I do? The issues here are several. The patient's on experimental drug. Should he be treated aggressively to see if the drug will work? Should the opinion of the patient's son, who tells you that he wants the patient to have full treatment, should that have any bearing on the case? The patient himself doesn't want more treatment. The patient's son wants to treat more aggressively. Should the cost of care have any role here? If the patient recovers from, say, going on the ventilator, should he then be placed on a tube feeding? Well, he gets a pneumonia, and the decision's made to put him on the ventilator, and he gets better, and he's taken off the respirator, but the whole situation's taken a toll on their finances. In Wisconsin, they're up in Wisconsin, and the question of whether he'll be able to get a home nurse comes into the play. We've treated him medically, but his situation is such that now he's limited by the financial aspects of his case. 6 months later, the brainstem component is advancing. Now he starts aspirating food. The issue comes up with tube feeding. Now the patient is refusing tube feeding, and again the patient's son is requesting tube feeding. What should one do? Another ethics consultation. Here, because the consultant knows that ALS spares the brain, and in terms of mentation, one would ask this patient to write an advance directive or to clearly state what he wants to do and document it, and you could get a list of the things he wants and doesn't want, and then you can discuss this again in a family meeting with the son and the patient's wife. One can predict what will happen in such a case. The issue of tube feeding comes up. If he doesn't want tube feeding, then the issue of the ethics of withdrawal or withholding of tube feeding come into play. In a rapidly progressive terminal illness like ALS, this seems to not be as much of a difficulty for many Christians, ALS or cancer or those kind of diseases, as, say, withholding tube feeding in patients with Alzheimer's or in patients with persistent vegetative state, because these patients are alert, are not clearly dying, they're not terminal. They may be alert if they're Alzheimer's patients, and it's much more difficult, it seems, to withhold or withdraw tube feeding from such patients. So again, the fact picture of the case changes the technology more than just the fact that it's a tube. Should we withdraw the tube? It's not a good enough question. In this patient, what are the facts of the case? So as consultants, we've gone through the different steps of consultation. As casuists, we just fight and scratch and claw to solve the case. We don't give up until it's solved. Whatever principles it takes, whatever amount of time it takes, we stay there till we solve the case. That's how you try to solve cases, and that's, I think, the art and the difficulty, the art and the science, if you will, of casuistry. Thank you.